So only she's left basically for intro. Okay, anybody else would like to?
Woman is blessed. Please introduce
Yeah, woman
yourself.
is blessed. If you can. Okay, so we'll come to her as we go ahead, and we'll come to many other people as they join. So, for the sake of time and maintaining the schedule for today's, we have divided. I mean, we are going to focus today on how to gain more referrals, as we read in the flyer, and we had been given 4 pointers for the same. So let's start with the first question on how OT practitioners in India are gaining referrals and which strategies work and which do not. Okay, so today we're going to discuss on those. So I would love to your thoughts on this. And it's a free platform, and you can raise hands or you can just unmute yourself and start. But be mindful, I mean, we are not cutting each other. So we would, if somebody is speaking and you all need to go next, you can raise your hands. Okay, and even chat is a good option if you want to post any questions or any ideas which may or may not be related to this topic, but you feel you would like to share, please do so. Yeah, so let's start. So how do we gain referrals in India? What are the strategies do we use? And which strategies we use, but we think that it doesn't work or it's proved that it doesn't work? Ashwini ma'am, if we can have your thoughts.
Pooja, my experience of receiving referrals has been over. I was briefly in India about 10 years ago, and at that time, I remember that there was a lot of confusion between referral to psychology, referral to OT, and in a clinic for children with difficulties. So I think I had to advocate a lot. That's what I remember. I remember the struggle part of it rather than something that can contribute to this specific question. So somebody else who's based right now in India might be in a better position to answer this. Sorry.
Yes, so maybe what we can do is, ma'am will come to you later again in terms of your current practice in Berlin and how you're gaining referrals there. We can have that as a last question, which would be a very lovely idea. So we'll go to other people first and we'll come back to you, ma'am.
Sure.
Also, Nidhi, what are your thoughts on this? How are we gaining referrals for as OT practitioners in India? What are the strategies working for you?
Okay, I am not in
Hi.
private practice, but I do know of people who are into private practice, and most of them agree that it always helps to have a good relationship, especially pediatricians, neurologists, and psychiatrists, not to forget the other specialists as well. So, and the main thing is that it always helps when we are documenting and getting back to them. So these are the key things which I have learned in gaining good reference.
So, Nidhi, you spoke about private clinics, but would you also working in any hospital or something, and you would like to tell about the strategies in the hospital or anywhere?
Sure. So in my workplace, the strategy is that every consultant has a caseload which is suitable for occupational therapy, usually refers them to us. And even if there is no referral, we have understanding of the caseload, we have access to the caseload. So we are also allowed to take up cases which we think will fall within our domain of practice.
So you're saying there's a direct access to the patients is how
There
you're
is
gaining referrals?
to a certain extent. I wouldn't say completely, but to a certain extent.
Okay. Shopna ma'am, you have raised your hand, ma'am. Thank you, Nidhi.
Yeah, I would like to, say that when I started my practice, private practice in India, that was about 10 years back. I had to mention that it was a little bit difficult to get referrals from the health professionals. So I used to get referrals from families, or maybe, like, say for example, if I get a client, and through the client's parents, and it mostly it's word by mouth, it passes on. But now I have to say that it's a chain of say, I mean, like, it's a mixed group of team. Like, there are psychologists, there are special educators, there are teachers, there are parents, and psychiatrists. They do refer nowadays, because I understand that there is an awareness now in especially in the pediatric population. There is much better awareness compared to the other population. So now it's a mixed group of, I would like, it's not a data, but like I'm not following any data, but like from my experience, what I actually observe is my first referrals are direct parents. Like they look for, like if there is an issue, they first thing they do is go to a doctor, and then they probably look in online. So they learn about OT, and then they look for where OT services are available, like, and then they discuss with other family members, and somehow, like, they reach. The second people that I'm noticing now is the primary school teachers. So the primary school teachers find there is a significant difference only if there is a significant difference. Otherwise, like, they even come a little bit late. And then the third population I actually see, the group of healthcare professionals, which includes doctors and psychiatrists, and even special educators, and all them. Like, they fall in as a team member. They make a referral. That I observe, but I certainly this reflect. I mean, um, this chat, the Saturday evening, reflects me to look into more kind of data collection maybe in the future to figure out. Um, but that's my experience. Thanks.
So that's a very valid point. And to summarize, she spoke about many strategies that, how we are gaining. And she even covered a point of who refers us the most, or who are the referral sources for OT in India. So, word of mouth, the team members, the online direct access or referrals by the family members, then other healthcare professionals, and now even the school teachers are the ones who are referring to us. So, ma'am, what would you say, or which strategies, or who of all these are referring the most? I mean, you said that all of them do refer, but which is the most, you know,
Yeah,
uh,
the first category, what I think the most trustable. I
yeah,
mean, not for us, between them. Like, if they come with a trust, that's the parent group, because
that's the
they
word of
heard,
mouth.
yeah, that they because they actually talk to somebody who had experienced. So they either it's positive or negative. So it is both. It's kind of a, like, customer satisfaction. Like, pretty much like, how is the service, and they like it, they spread it. If they don't like it also, they spread it. So that's the first thing. The second group, I mean, like, it doesn't happen in one day. Obviously, I mean, the set of referrals that I received probably had a background. I would say that it's not a planned thing. Say for example, the primary teachers who refer, so those teachers probably I would have conducted some workshops in many years back. Somehow, like, maybe a parent would have seen some changes, and she would have put some word to the principal, or somebody else, or maybe the teachers has noticed some significant changes of that child in the classroom, and they approach. They would have probably asked for a workshop, or maybe for a webinar, or not a webinar, but like, in service, or just orientation to the teachers, like how to identify. So that may probably happen years back. So, but it is carrying on, like, those teachers, because nowadays sometimes the teachers say that, yeah, I had listened to your lecture, or I've spoken, you have spoken to the school years back, and I still remember that, so I think that this child might need an OT, and then they come. So that might have happened. And coming to the health professionals, especially psychiatrists, not all of them would, but there are a couple of psychiatrists, again, only if they see a significant changes on the clients, then I would say that they would probably refer or write to you. Most of the time they write to the parents saying that you could approach so and so, and get it sorted. And I think in Tamil Nadu it's better now, because there are probably a lot of centers in Tamil Nadu, and there are a lot of occupational therapists, especially in the pediatric population. So there is much awareness. So many doctors come to know, and in fact, there are list of clinics being provided to some doctors, through the associations, and through other people. So they are aware, and they have the addresses and stuff. So if a client approach them, they look into their the list of clinics, and they refer. That is also happening, obviously. But the high number of referrals, I would say, it's from parents directly, like
Yes. Uh, I mean, it's a very valid point you spoke about, that even the indirect word of mouth method, that appreciation of the progress and the uh, success that we provide via effect of our therapy on a child, it lasts long, and even after 10 years, you're getting the fruits of those, and that is actually an excellent and the key and the crux of it. So another that you added was the awareness. I mean, you have an excellent awareness in your area, and that is how you're getting, so many professionals and other sources are referring. So that would also be one of the strategy that could, I mean, work would be awareness. And you are doing webinars and workshops, which are also, I mean, that's how you're creating awareness. So that's the strategy that's working for you. Uh, uh, so, anybody would like to add something to it, or have a different perspective, or would like to share? Ashwini, ma'am, you've raised your hand, ma'am.
Yes, thanks.
Hi.
So going back to what I said about advocating for myself several years ago, I think what also helped me was having regular meetings. I was lucky to be working with psychiatrists and neonatologists who were very open to all professionals working with them. So they would meet regularly with us because we were new to them. We were new to each other mutually. They would discuss, they would ask if the referrals were appropriate. So that also helps. So having regular meetings, if that is possible in a setup where you are physically located close to each other, that helps. And I see that relevant even now, right now, where I am new to a team. I see it's relevant to have those meetings to find out, okay, maybe this needs to go to somebody else. So to match the challenges and take it forward from there.
So the appropriate referrals also are one of the key, because uh, we can give a very you know appreciable results if it is appropriately referred to us. So that's a good point, ma'am. So for the sake of time, we'll move to the second question, which is, what are the challenges? So ma'am spoke about challenges of awareness, challenges of appropriate referrals. So we have covered 2 points on it, but we would like to hear more about what are the challenges that we are facing in gaining referrals, or maintaining them even. So who would like to go? Karthik sir, you've raised your hand. Yes.
Yeah, so I just kind of raised in my hand in response to the first item that we discussed, and also I'm just kind of really was simply nodding a lot when Dr. Shavnamurthy like spoke about the referral sources and stuff. So I practiced like almost a decade ago, and I had my own private practice, and it's still the same. It looks like it's still the same because I gain a lot of word of mouth referrals. So bottom line is outcome speaks. So if you were to deliver good therapy and if you deliver good outcomes, it speaks and it gets you more clients. And a couple of other strategies that those of you are looking for some referral ideas here, how to gain more referrals, ideas for more gaining more referrals. Then one idea that I did that kind of worked favorably for me was I launched a newsletter. So to all my clients, to all my past clients, to all my referral sources, and anyone in the public, just kind of like created a useful article every month that they can like know anything about a behavioral control or how to handle a particular issue with a child or something relevant to them, as well as also kind of educating the referral sources in terms of what are all the issues that we could address. So I just kind of used it as a visibility marketing opportunity as well as an educational opportunity, when I was actually practiced there. But then I continued to do that for another 9, 10 years after I came to the US for just for educational reasons as well. But that's something that you could consider is basically you collect email from all your clients as well as your referral sources. If you can look at their business cards, you can get it, and then maybe just kind of like try to develop some snippets of information every month and then like spend some time. It's once a month, but that kind of like keeps on like putting your name in their radar. So when they have a client and they when think about an OT, your name comes top of their mind. It's very fresh because you keep sending some information, staying in touch. And also the clients you discharge from therapy, they may have a relative child or someone, but if you constantly keeping them in the loop, they might still act as your referral sources. That's a referral idea that I want to give for those who are looking for ideas. And I totally agree with communicating back to the referral sources is one other thing that I did that worked favorably for me. So whenever I send a report or a progress report or give my opinion on a case that they refer to me, it shows that I'm valuing and I'm working on it. I'm taking it seriously. That builds the trust with my referral source. That gets me more referral as well. So yes, you need to nurture not a key professional relationship with your referral sources. That will work favorably as well. Then yeah, I mean it looks like definitely the visibility has gone up in Tamil Nadu, given that there's a lot of clinics and also the number of institutions are going up. So when more people out there, obviously that leads to more visibility, more education, more awareness. That's a good thing. But I think we need to be a little bit more strategic, so that we are not seen as pediatric professionals or pediatric therapists alone. We do have a role, wider, larger role in other areas as well. So we need to be conscious so that we do not like let that shadow fall upon us. So I want to say that. Um, and pretty much I agree with all the referral sources and ideas put forth by Nidhi as well as Mr. Shabramurthy. Uh, Given that we are already into the second question, let me quickly say something about it, and then I'll turn the control over to the next person. So the challenges that I think, in my view, are the first thing, obviously, the lack of awareness. So even like those professionals whom we talked about in the last section about referring clients to OT, do they really know what we exactly do? Right? They might have come across some of the in some conferences or some online resources that OT might benefit these kind of diagnosis. So basically, most of the referrals, if the child has attention deficit or autism or something, okay, send it to speech and OT. That's all. But they do not exactly know what we do, how we help them. Not the technical details, but at least we know when we send a patient to a neurologist, we know that what the neurologist does, right? They do a neurological examination, they do some investigations, and they do EEG if needed, and then they prescribe medicines. At least we know the outline. We do not know the details of it. The same way, they need to know what we do. What are the areas we address. So then they have a little bit more information. So I don't even the sources who are referring to OT do not have that idea now. So I think we need to really make ourselves more visible in terms of what we do. And for that, I think we need to start with documenting things. So we need to start good documentation practices, and with that we need to generate more research. We need to publish case studies. We need to present in conferences like interprofessional conferences where other people are sitting and listening, not only in the OT. Of course, it's important to build the OT science, but we also need to step out of our industry, and then educate the other stakeholders in terms of what we do is what I think. So the biggest challenge would be the people need more visibility in terms of what we do, more idea in terms of what kind of problems we can deal with, so that a geriatrician can refer clients to OT, and neurologist can client refer to OT. Because in my early years of practice, I had a huge challenge of convincing the professionals to refer clients to OT. I managed to convince an orthopedist and a cardiologist to send me all their cases to me, and then I was like ran a busy clinic in that hospital. But then it was a bit of a challenge for me to convince the neurologist who always sends patients with stroke or other issues to PT. But even though we have a bigger role to play and we can do a lot of wonderful things with patients with stroke, I managed to it was very hard for me, because I think they're just kind of like shut in their perspective, and they are not like it's very hard for us to really bring them on. And that's why I said we need to generate more evidence, more scientific sources, to convince them that this is a viable profession, that can make some meaningful contributions to neurological rehabilitation. So we have a long way to go, but things have been improved definitely from when I practiced in India to now. But still, we have a long way to go, is my opinion. Thank you.
It's an excellent, list of points for both strategies that work for our referral, as well as the challenges, and even you provided with few solutions of how to deal with those challenges. I'm pretty happy with that. So to list the challenges that Sir said, one is awareness. Second is the clarity of the referral, that what exactly do we do and why it should be referred to us. And for that, Sir has given us a solution. The great solution is documentation. Documentation in any form, documentation in terms of sending reports, documentation in terms of publishing papers, documentation or presenting in inter-professional conferences is what Sir, any kind of symposiums, etc., to have a clear idea of what exactly we do or what problems do we deal with. So to add to that point, one more solution which I could think of are the referral pads. The pads where you can have a checklist of, the list of problems that you work on. So, we would like to refer patient this for the following, and something in the list of the problems there. So that could add. Sir, yes, sir. Please.
I add to that, I tried that strategy a long time ago in the corporate hospital. Okay. But again, it depends on the people that you work with. Some people really work that, but the referral pad was sitting in literally what you said was I did. Like I'm talking about 2007 to 9 time frame. And it was like, it was all in all the consultation office rooms and all, but it was like way bigger than the 3 or 4 pads, and it was never looked at. Okay. So I think, there are some challenges, strategical challenges, but again, I'm not overruling that idea, because I did that idea. I mean, I know it's a wonderful idea, but I think, it depends on maybe the hospital has to have a system in terms of all the profession and all the specialists who deal with their cases must, check off on certain things. If there is a system that they need to follow, and OT is one of the things that they need to review and then make a referral if appropriate. If that is part of the hospital culture and system, that would work fantastically. But yeah, we need to really work. There is a lot. I mean, what I said is maybe one side of the coin. Like there are multiple perspectives. Yeah. That is why I really want everyone to talk. Is like that's my idea, my 2 cents. But I really want everyone to contribute their 2 cents. Thank you.
So to add to that, sir, I have not used that for doctors. I mean, the idea of referral pads, I had used it for schools. I mean, school counselors, the counseling department in the school, because my major source of referrals are schools. And word of mouth, as you said, I mean, as ma'am said. So I had sent it to school and it works wonders, sir. I mean, counselors do, pick up and send. And because they are always on a lookout of who can help this child as they have to send. So it works wonders with them. And I had actually not given a referral pad per se. I had given a kind of a letter or a poster type, bigger one, which they can put it in their softboard, which they had kept it there on a softboard for everybody to see that if these are the issues in the child needs to be referred to OT. May or may not be referred to me, but yes, my name was there below, so they would refer, but at least the child gets referred to an OTist. That was my point fantastic. Of doing that thing. And that had worked for me, but I had not done it for doctors, sorry.
No. I mean, that's fantastic. Thanks for sharing.
That's so anybody, I mean, we had a healthy discussion here, but I'm still open to more ideas on, because it's a very important point. Yes, Shaileja ma'am.
Yes, since I have also done a lactation consultant course, what we have observed is if we go and meet the consultant in their respective hospitals or whatever it is, and if we request them that for your patient, we can give one free session, the group of the patient, maybe 3 or 4 patients together, and we give you a free of cost session where
Hmm.
maybe the consultant, if he or she has a time, will attend your session, or through a word of mouth, like from patients' impression, if they come to know about our profession well, I think that is a maybe we have to give some extra time, but that will create a forever awareness in patients.
So yeah, I mean, direct solicitation and some kind of, uh, you can say offer, not offer, but some kind of extra efforts that, or extra attention that we could give to people, definitely gives a lasting impression of us as a professional, as an occupational therapist. Ma'am,
Yeah.
very important point and very valid point. Thank you for sharing, ma'am. Uh, Anybody else would like to share? I mean, there are many people who haven't spoken. Nidhi, yes.
Yes, and
Hi,
adding
Nidhi.
on to what
Yeah.
Lailaja ma'am said, we followed a similar strategy for gaining referrals from the oncology department. We did a live demo with the consultants and the patients, and actual patients in front of the entire audience. We demonstrated to them what all we could do to help them out, and that is how we started gaining more referrals. In fact, we heard of doctors telling us that patients themselves are asking, some patients. So that is something which actually works out well, especially in niche areas. Just as ma'am said, lactation is a niche area where not many of us are aware that OT does have a role. Similarly, in onco also the awareness remains limited. So in these niche areas, I think that strategy will work out well. Thank you.
Excellent. Excellent, Nidhi. Very valuable information that, and I like the idea of live demo. You know, it should be tried for other areas as well. I mean, we as pediatric occupational therapists haven't, but yes, for different areas, and as you said, the niche areas where we can provide valuable, so definitely, I mean, very happy. Somebody else would like to add to it. What about Lakshmi, ma'am?
I
Hi.
I would like to add something.
Yes, please.
Sorry, I just joined the meeting, but I could get the pulse that it's something related to, how do we get referrals and how do we, how do we let other professionals know of what kind of services we could provide and be a valid team member, right? So I'm sure I'm on the same frame
Yes.
uh, because I'd like to share something. I work in Muscat in the Ministry of Health hospital, tertiary care hospital for the past 20 years. So when I had come here, occupational therapy, the way our occupational therapist at that time had portrayed OT as, he was literally called a splinting man, you know. So he had portrayed that OT is all about splinting, going to into the environment, into community, making adaptive device. So and we are tertiary care. We had ortho, neuro, pediatrics, neonatology, everything. But people knew OT as splinting. Then when I had joined, it was a nascent stage when I was very upset and I had to portray that what all services we can actually provide. So what I used to do, I used to go to all the ward rounds, literally the whole week round. And I used to say, oh my God, in this patient, me as a team member, I can do this. In neuro cases, in ortho case, ortho not much, but neuro cases, in plastic surgery cases, plastic and reconstructive. So all those specialties. So then they used to say, oh, really? You can help this patient. Then I used to say, please give me a slot in your morning CME meetings and I'll present what we can do. So I used to give lectures. I had to post myself literally, and gave lectures in almost all departments. And then they started realizing, oh my God, OT, you can do this. And things like desensitization therapies, amputation cases, nerve reconstruction cases where there was, allodynias and all kind of phantom pains and sensations. So those things was literally, rocket science to them. They said, really, you could help so much in all these. So that's how I had to push myself into. And I suggest that all OTs, because, off late, I was just thinking to myself, I was thinking aloud, and I said, why OT doesn't have an identity still? And then I realized, our name, the profession name, I think causes a lot of confusion. Because when we say we are an occupational therapist, people say, what exactly do you do? We, for ourselves, it took a while for us to understand what we do. We bring back a person into his occupation through an occupation, right? And provide him and or get him back to a modified or same occupation. So whatever. So it took a while for us to understand. Then when it comes to explain to people what an occupational therapist does. So I think fortunately, unfortunately, the name, creates the confusion. So I don't know, that's a global picture where we have to work on. But then, so what we have to do is we have to actually push ourselves and let people know. And another unfortunate thing is in our hospital down the line, 20 years, doctors keep changing, nurses keep changing. So every now and then, don't think that we have given a lecture and they know it. People have changed. So keep time and again, time and again. Now I train my juniors and junior staff that yes, push them, go give a lecture here and then let them know what OT is. And then World OT Day. Every year we do awareness programs in our own department, and we have footsteps towards all the departments, including administration, to departments. So they say, oh, there's something going on in this place. And then they realize, oh, the department is here. Wow, wow, what do you do? And then we have questions and give away gifts and goodies saying that how much, including the medical orderlies who are the support staff or the admin staff, everyone. Yeah. Because this is how people now in our hospitals know very well what he does. And in neonatology, in ICUs, they actually don't discharge a baby till OT gives the sign, says that, okay, the child has established feeding and has said that, yeah, we can discharge. Otherwise, if one of us is not present, we are on leave or something, then they contact OT from other hospitals and they say, please, can you come and assess or evaluate the baby so that we can discharge. There, I'm proud. But then not really proud. I say that all of us should work um, towards this direction, There's no harm. Keep explaining to people, because what I feel is OT can do a lot. So why not spread your resources and help people? Because we can do a lot. That's my take on this.
Thank you so much, ma'am. And ma'am gave us a very important points and several points of hospital. So till now we were discussing about private clinics and how, as an individual, we were advocating for ourselves and gaining references. But for ma'am, am I audible?
Yeah, Pooja, but there's a background noise that I'm trying to control.
Yeah, there is some background noise which even I can hear too. So if everybody can mute themselves so that I can, yeah. Thank you. So to summarize the points that ma'ams shared that about how to gain more referrals in tertiary care hospitals where there are many departments and many areas to be worked on. So according to ma'am, we need to be proactive. We need to push ourselves and self-advocate on regular intervals. It would not be a one-time effort. It has to be a regular interval, and to be constantly in the radar of the professionals who refer to us. Also to let other people know what exactly do we do, give lectures and CMEs about our roles, and show them how effective an occupational therapy is, and that's how to keep creating awareness. And the important or key point that I liked is to do it on a regular basis at regular intervals, as there would be a turnover of doctors, there would be a turnover of people who are referring. So we need to constantly keep doing. Yes, sir.
Let me unmute. Okay. So a couple of things just to build on what Nidhi said and Lakshmi ma'am said. In talking about the niche areas, I'm kind of really like seeing that from a little broader perspective. Like we need to provide solutions to the need. So if we were to definitely identify what the society needs, what are the healthcare needs that are unmet, and then what can we do about it from the occupational therapy perspective. We can gain more referrals, right? Say, for example, all these people, when you said, Pooja, that, the teachers were wondering, they really want the kids to be helped. And they were kind of really looking for how the kid can get the help. And then they were looking for the options available, and they come across occupational therapy and they send it to us, right? So basically, we need to really understand what our Indian society needs. And then as long as we try to solve or provide a solution to a need that's been existed, I think our visibility, our need will grow more. So we need to go in that direction is first thought. And then with regards to like Lakshmi ma'am's comments, it's all wonderful thing. And like the key takeaway there is we need to be, like the business as usual won't work. We need to be a little bit more, have that self-initiative. So I think more and more OTs, instead of just kind of going to do their job and come back, they need to be an advocate for their profession, for our profession. So that self initiative is what needed to push the boundaries and increase the visibility and awareness of our profession in all the type of settings that we work with. So that and just Pooja, there are some more few peoples like Selva, Srinivas, and Priya, and all. So if you want to have a chance for them to introduce and then share their thoughts, that'll be great as well. And I see Sobra ma'am's hand. So first you would like to invite her, and then we'll go from there. Thank you.
Thank you, sir. Shobna ma'am, would you like to share your thoughts?
Yeah,
Yeah.
just a quick one. I mean, after listening to Lakshmi ma'am and the other ma'am who had raised a very valid point of, how you need to self-initiative yourself and advocate for your profession. What I see here is what she's probably doing is a very valuable team collaboration. So she's constantly collaborating with her team members, which is happening. And even if she isn't there, like they acknowledge, they recognize there should be a team member who needs to fulfill her role. So that is the success of our profession, and very good for that. I think we all should practice that way. I mean, I'm seeing, like sometimes like occupational therapists are so much into towards themselves, like within ourselves, like within our team, within the OT members. But like we really got need to spread our wings and have a team collaboration, which would definitely promote our professional development. I just wanted to add that point. Thanks so much.
That's a valid point of collaboration. So now,
I'll add one quick.
yes,
I won't take much time. Can I just add one
please,
point?
ma'am. Yeah.
Yeah, so sorry to take a second chance, but then I just wanted to, especially to the younger generation, to the newly entered occupational therapists into profession, that first of all, be true to yourself and your profession. You have to clearly understand what is occupational therapy to practice a very, very genuine profession. So what I feel is we often, many times, the younger generation, the new OTs, what they say that, there's encroachment in profession. PT, speech, they keep doing a role, and then, there's encroachment. I tell them that, I had very senior professionals in my hospital when I had joined. I was literally a baby there and speaking big words. So, in Hindi, you say, choti muh badi baat. They used to all feel like that for me. And they used to say, oh my God, she's just come and that too landed from India. And then she talks so much. But then what I realized is that, okay, you should know to put your foot down. You should say, this particular thing, a physiotherapist can help. Let me refer to them. This, a speech therapist will help. What happens tomorrow? they very easily and comfortably refer the patient back to you. Another situation. So what happens, that gap, that ego between the professions vanishes because you are readily sending the patient to where he can benefit best from. Same thing happens from prosthetic orthotics. What happens is splints we make, they make. But what happens that very well I demarcate, I tell them, okay, can you please come over or I'll come walk with the patient to you. We can discuss which kind of splint helps them best. So, you always put the other professional on a higher pedestal and they will put you on the same place next time. So this is how teamwork happens. So never go into ego issues as to they are not referring, I am not going to do. Be genuine and just think patient centered should be your thought always. Then you will never go wrong.
Yeah,
Excellent,
I
and I
was
Thank you
looking
so
for
much.
that word. Put the patient
yes,
first.
patient
Be
centered.
patient
And
centered is very important. And one comment that I want to make about the talk about the terminology of our profession, the occupational therapist title itself is a little confusing, and I totally agree with it. That's kind of created a lot of chaos in terms of how people see us. Because like when I introduced myself as an OT back in India a long time ago, so it's like, do you work in employment exchange? So I think the word occupation like kind of like connotes to work in general meaning, but the way we see in OT philosophy, occupation is everything we do. All the meaningful activities we do, all the daily activities we do. So I think yeah, we need to really explain. Maybe in the very first encounter with the patient we need to tell who we are, what we do to start with, and then go from there. That's one thing that I always did is like in the very first session after the consultation or assessment, I tell them what is OT and how we can help, and then I will tell them about the individual treatment plan. Thank you.
so that's a very valid point, that even our clients need to know that how and how much can we help. So, and to add to the point of Lakshmi ma'am, an excellent point. I mean, that's how actually even, we should be creating awareness. We should be creating awareness more from what clients need or how we can solve the client's problems. And it should be more of client centered and client from client's perspective, so that they would know that how we can help. So a very good point. And uh, let's I mean, there are many people who haven't actually spoken yet, so let's give them a chance. And and since they are not raising hands, so let me ask Chiruba ma'am, would you like to share your perspective, your thoughts on how we can gain more referrals? Where did the ma'am go? Hi, is she there?
I'm not seeing her.
Yeah, me too. So let's go to other people. Selva ma'am, you haven't spoken yet. Ma'am, would you like to share your thoughts on how what strategies work for you, or any thoughts, or you have a different perspective about what we spoke? Priya ma'am, would you like to add a few points? Yeah, Selva ma'am.
Okay, yes.
Please.
Selva, sir.
Yes. Okay. I am working in a special school in Bangalore. So we have the team
Sorry, so.
because physiotherapist and occupation therapy, we are in same room, same space only. So still now, but we have the clear vision of what they are doing, what we are doing. So the differentiation is needed. So because we literally tell that we are only focusing on fine motor and sensory, and as well as the ADL. So based on the sensory related and fine motor related ADLs, we are focusing. I'm focusing. So that clarity we are make the partitions in the physiotherapy and occupational therapies. That and one more thing is what even I agree with Lakshmi ma'am and Karthik sir, what they are saying, self initiation is needed, because still now in Tamil Nadu south area don't know about it. In only city side they knows what is occupational therapy. If you go interior little bit, they don't know what is occupational therapy and all. So we need more awareness on it, and the initiation. We have to come up with a specific areas, and we have to explain to the doctors and the other professionals.
Excellent. Thank you, sir, for sharing your thoughts. We'll move on to other people who would like to share. Priya, ma'am. Yes, ma'am.
Priya, could you be a
Can't
bit
hear you.
louder because we couldn't hear you properly? We know that you're saying something, we couldn't hear you.
Hello. Can you audible? It's audible?
Yes.
Yes.
Yeah.
Yes.
So
Yeah, it's better.
I just points like it's good that we can refer through the doctors, and the first and foremost referral be from parents, as Shobna ma'am told. So that is the best and trustable point that she added it. So through parents, we can have a very good referral, and the challenges and the awareness part. I'd like to add some points like regular demo, hospital ways, yes, and in a private setup, I would like to newspapers, pamphlets issue, or any like Karthik sir told, any kind of awareness regarding a particular topic or any depth also in sensory integration is in depth also in a area or in sensory, but one particular part, so that we can include those points, and we can create awareness in a public, so that they come to know what is what, and they may be in some places, the people will come to know the problem that child is having, and they may be refer to our center. So like we can have some more points in that, and the client maybe get referred to us. Thank you.
Okay. That's a a good points that you shared, and thank you for sharing your thoughts. So what Priya ma'am said about referrals, it's the direct word of mouth from the families, and regarding strategy, she spoke about doing regular demos and pamphlets about the problems or the areas that we can provide services for. So that's to summarize her. So now, sir, you would like to speak something? So one more point that I would like to understand is this is how we are gaining referrals or in India. Now, we would also like to learn how things happen abroad, in other countries, so that we can learn and empower ourselves, grow ourselves, and maybe we can learn from people who are working abroad. Sir, you would like to start the wagon?
Okay. So, again, here is a system that helps the OT profession. Because, for example, there is a legislation called Individual with Disabilities Act, where the schools are required to provide enough support for children with special needs to succeed in their education. And fortunately, the law identifies under the special services, one of the services listed as OT, right? So there is a process. All the childs are are screened, and then if there is any, they have like a sort of a screening tool for everything. And if the child really fell below a certain level, then it needs to be referred to these services and get their opinion and develop an individual educational plan. The parents need to be involved. I think the system kind of favors, so they cannot really go beyond, step outside the system. So that's one thing. And when it comes to the second thing that kind of works favorably in the US atmosphere is the reimbursement sources. It's in India, it's pretty much out of pocket, right? The client has to, mostly it's still out of pocket, so they have to pay. And so it means that we need to get their buy-in, and they need to they need to feel that it's worth spending to pay for OT services. So we need to convince them to that extent. But in the US system, where the Medicare or the third party sources is what pays, and then they say, oh, you're covered, like, most of the, even the private insurance say 30 sessions per calendar year or per plan year or allowed or something. So what happens is they need to still pay a little bit of copay, but they say, okay, I mean, my doctor says that I might benefit out of this, and that there's not much cost to me in this. Why can't I utilize the benefit of it and then like go for the session? So that kind of, like, again, when it comes to inpatient post-acute care, the Medicare really reimburses for 100 days of care, and it's like more of a 1 day of stay, kind of includes all the nursing, OT, PT, everything in it, right? So the reimbursement system also kind of works favorably, and also the lot of science and data that we have, the AOTA and the other state branches here, like, kind of really, they do the AOTA Hill Day, like, they go and talk to the legislators to make them realize the importance of this. So there is a legal safeguard, a lot of political advocacy going on one side. On the other side, there's a lot of resource, multiple OT journals spreading up-to-date research on each and every topic that you could think of, a big conference to promote, the science of OT here. So all these, the documentation aspect, the reimbursement aspect, and the system in general kind of works favorably, kind of like, everything works in a flow. So all the patients will get referred to OT per the system or per the hospital guidelines. And all these things are very beneficial and profitable for the entities as well. So they promote all these things. So as per the Bureau of Labor Statistics, there is a like a projection of 16% growth in terms of OTs need for the next 10 years. So more and more OTs are needed in this country, despite we are already like there are 200,000 plus 213,000, 214,000 OTs currently, ballpark. But still, there's a 16% more need, in the coming years. So at the moment, we send our graduates out of our school, they find a job within a matter of weeks. So that's a scenario here. There's always a growing demand, and also, the lifestyle contributes to it. Here, everyone lives alone. Sort of a like in India, it's like more of a family-centered cultural, but here it's more of an individual-owned thing. So everybody wants to be independent. Do not want to be dependent on others and stuff. So the concept, the Western concept of independence, kind of works favorably to the OT philosophy of facilitating independence, right? In India, if one person is sick or disabled, there are multiple people to help. But in the US, like, everybody is doing their business, and this person has to really find a solution for their own problem. So then they need OT, they need these gadgets, they need the training on how to use them. So the culture, mindset, system, science, history of the field of 100 plus years, all these things work favorably in the US. So now I would like to hear from other people from other parts of the world. Thank you.
Thank you, sir. I mean, to share, your insights about how things work in US. And we have one more. I guess we have one more person who has worked, who is working abroad. Ashwini, ma'am.
Yes.
Would you like to add something to what sir said? Yeah. How things are in Berlin? Like, I mean, how, what are the favorable things, or what are the challenges that you all face there in gaining referrals?
So, having practiced in Ireland before this, I'm recently new to Warsaw, Poland. But the public system is where I have always worked. There was always a very clear referral pathway, and the presence of occupational therapists in multidisciplinary team meetings, which is the referral, which is the point where the referrals are made from the consultant to the therapist. The presence was always there, and somebody echoed that earlier. Even if the head cannot go, the head from the department cannot go, somebody else needs to be there, because unless people know what they're missing, they're not going to know unless it's made visible to them. So basically, there's a very clear referral pathway. So all primary care hospitals in Ireland have a strong occupational therapy department, of course, backed by the Association of Occupational Therapists, which has had a steady presence in the last 30 years. And I worked in school systems, in public school systems, where there were always annual workshops for teachers. So any new graduate, any new teaching graduate was exposed to how OT can help a student if she needed to make a referral. So we would do those quite consistently, those workshops for awareness and explaining what we can do, right? Now, Poland, I would say that in terms of occupational therapy, has a trajectory which is probably similar to India. it's growing. I don't really see visible professionals in the field. It's not understood. It's not. I think there's a long way in terms of how it needs to evolve here. So there are sensory integration therapists, which means that I really have to explain that for a child, it's not just about sensory integration. It's only one aspect of performance. So I have to advocate there, which means that compared to Ireland and here, I have a long way to go in terms of explaining when a referral should be made and how it can help. So I think in terms of niching ourselves, we probably have niched ourselves too much into the sensory integration bracket in India. And we need to be seen beyond sensory integration and beyond pediatrics. And Karthik made a very valid point about interprofessional presence, interprofessional conferences, teams, whether that is a small team or a big conference platform. So we need to go beyond pediatrics as well. And I think, yeah, I have mentioned the differences here.
Yes. It was very insightful, ma'am. And I'm not sure if we have any other people from abroad to share their perspectives, but if somebody has been abroad and been back and would like to share their experiences of working there.
I would like to share, as I mentioned already, I work in Sultanate of Oman, Muscat. In fact, me and my husband both are occupational therapists, and we've been here for the past 20 years. And we've always been in government sectors. We are working directly for the Ministry of Health, and he's in the only and the biggest psychiatry setup hospital, and I'm in the tertiary care, as I already mentioned. So here there's a lot of difference. First of all, because this is a government, we are in Ministry of Health, so there's a lot of bureaucracy. We cannot put our pictures of clients or ourselves even in social media, and we cannot put it on things like Snapchat or Facebook, what our services are or how our patients are benefited, and small videos or reels. We cannot do all that, and that's one very important and specific point. We can't do a mistake there. Secondly, then how do people come to know about our services is, as somebody already mentioned, word of mouth. We have to really give quality service here. And more than quality service, a very, clear-headed identity of yourself. Not, via kind of a service system here. It's very clear, and sometimes where there is no clarity, you should advocate the clarity and should be the first one to say that this is not our role, this is somebody else's role, and this is our role, and let me do this. So you have to be so that firm and crystal clear with your own concept. That's one thing. And secondly, it's a beautiful thing that, I'm telling about my situation because we are not in private. We can say black and white things here. We can be true to our clients and we can say this will not work, this will work, 13 sessions, 10 sessions, and this numbers don't work when it comes to rehabilitation, and especially in pediatric cases. So yes, as ma'am mentioned, we have to go a little beyond. Though I am into pediatrics, I'm head of pediatric OT, and I am sensory integration therapist. So here we work a lot on translations as well, because in government sector, the local population are treated and the expat population have to go to private sector. Private, we don't have much of patient safety services. So in those cases, because of because the RAPO and the good services, here they have given me the permission to, get expat patients into government. So I can proudly say that they trust my service and they say it's okay. When you call an expat patient and give them a file number, we know it's needed. So that kind of service and clarity one should have, and we should be very honest to the profession and our clients. So, and we are working a lot on translation. We have the whole SI, assessment, the theory, everything's translated into Arabic. So we provide those to our patients along with English material, and we have handouts for every little information. Even we make a splint, we have a handout how to take care of the splint, because this is a very hot country. how not to in what places and stuff like that. So, when a patient comes back for a new place, they very well know the instruction and they see how we are not supposed to. So the handouts are so damn clear. And we work very hard through these years to make all those handouts. So I feel that, you have to see the situation where you're working and do the best possible and to reach out to your client mainly and to your team members. So I think
Thank
that's
you so much,
because
ma'am.
your work is difficult with these languages. So we have learned the language very well, Arabic. So all these little things, you have to do for, professional proficiency, I would say.
Well,
Just
thank
one
you.
thing to add,
Yeah,
to
yes, sir.
Dr. Lakshmi said is, yes, we need to be definitely be clear in terms of what OT is, what we can do, what we cannot do, and also we need to respect other professionals. But just to add to that is, we need to also think about our competency, right? Because an OT can do XYZ things, not all OT can do XYZ things, right? I may be very strong in one area, but I can just do very small splints. But if there's if it's a case like a nerve injury case where I really think I would be very comfortable in referring to another OT who is very competent in building splints. Okay, I'm an OT. Yes, I have the rights to do splinting, or I can even send it to an orthotist who has more expertise. So that is what we need to be like. Yes, under the OT label, we can do so many things. Yes, at the same time, we need to really reflect on our competency, and we need to either build competency if we want to do that, or we need to be do that we are whatever we are incompetent with, and then be comfortable in recognizing a fellow professional or fellow OT or fellow different professional, to do that for the benefit of the client. Just to add to that, thank you.
Thank you so much,
Yeah,
sir.
and also, when we are
Yes, ma'am.
when we are
I'm
talking about
really
referrals, we
sorry.
should get referrals. So we should know how we should, react to the referrals as well. Here, what happens, a lot of stuff, and I keep insisting with my colleagues that please, we are not technicians. When somebody refers some patient to you for a particular therapy or splint, you have to even then evaluate, complete assessment
Yes.
has to be done by an OT. And you can very well advocate and say this splint will not have help. Instead, I have a plan for this. And I will be doing this. Give me the chance to try this. So that kind of advocacy will actually put you a level higher, and then they will all come back to you for suggestions and information. So I think we should not work like technicians. We have our own knowledge base. We have our skill proficiency. We have to use them every time. And secondly, for the referrals as well. Sorry, I think I'm taking too much. So I should give somebody else a chance. This is
No,
the
no, I mean, I
important
totally
point I
agree
wanted
with
to tell
you.
was that
Yes.
don't just get excited. You should know how to use that referral as well.
Yes, very, very valid point. We need to be oftentimes in most of the time in the US and all, they only put OT, eval, and treat. So we are evaluating and we are determining our treatment plan, rather than, in some, parts in India, I've seen they prescribe the intervention and then the OTs or PTs need to really do that. I've seen some of the PT colleagues feeling very bad about ultrasound 10 times 20 minutes. They literally put the protocol on the referral pad and then they simply come and show it, and like a technician they put things on, they do it for 10 days and send them back to the orthopedician. That I felt very, very bad, because then why are we learning all this information, right? So we need to definitely, I'm with that, a valid point. Thank you for sharing that.
So Ashwini ma'am, you
I
have
see.
raised your hand. Would you like to share your thoughts?
Just a very quick addition to what was being said earlier. I think advocacy with very judicial use of our competency comes also, there's also ethics as a professional community, which feeds into that. And unless we all agree to something as a professional community, going forward together in a consistent way can be challenging. So I think this touches on another topic, probably for a future discussion,
Yeah.
but
Yes.
just thought it's valuable here.
No, it's a valid point, and definitely, sir would think about another Saturday night chat for the same. But it's a valid
Already.
point. Yeah.
Yeah.
So before we wrap up for today, because we have utilized and had a great discussion, and everybody has given very insightful thoughts, they've shared experiences, ideas, and we even learned about the differences of how the US, referral systems and the policies there, etc., are in favor of OT, and the reimbursement system over there too adds to, clients taking chances of, let's try, why not kind. Uh, since here it is out of pocket, clients would be like, "Key, let's wait if things get better on its own," or etc. I mean, things, the psychology aspect as well. And as Sir said about the socio-cultural differences, about the living style there, and your also makes a difference. So, in all, we had a very excellent, Saturday night chat today. But I would like Sir to say a few concluding words and maybe conclude as well.
Sure.
Yeah.
All right. Thank you so much, everyone, for contributing to the discussion. I hope this generation, this